action plan.
Welcome at this side, hello.
Over to you, sir.
Am I audible?
Yes, sir.
Audible. Audible? Yeah.
Yeah,
Good
audible.
evening, all. Yeah. Good evening, all. Respected our leader and state president Nandakumar sir, National IEP President-elect Singaravelu sir, the speaker for the day, our past national president Dr. Nitin Shah sir, uh, Dr. Nandish, Dr. Jayaraman sir, then my own convener, Dr. Shweta, IPP, Dr. Riaz sir, then our coordinators, Dr. Jijo, Dr. Meera, Dr. Sajna, Parvati ma'am, other seniors, and dear friends and colleagues who have joined today on this platform. I would like to place on record my warm welcome to all of you for this second program of Back to Basics. And I would like to welcome the office bearers, Nandakumar sir, the state president, Shinkaravelu sir, the national IEP president, and Nitin Shah, the speaker for the day for this event. And basically, I would like to place my gratitude also to Dr. Nitin Shah sir for readily accepting for this talk today without any hindrance and at my first request itself. Thank you, sir.
Thank you.
Now, I would like to invite Shinkaravelu sir, the national IAP president-elect also. I welcome him for being today, being the chief guest for the day. Thank you, sir. And I welcome all the seniors, the past state presidents, the office bearers of IAP Kerala, and my own team at Back of Basics to this program. And I would like to welcome all those who have joined today on this platform. Looking forward for a very fruitful session. Thank you. Jai Hind, Jai IAP. Thank you.
Thank you, sir. We are honored by the presence of respected President of IAP Kerala, Dr. Nandakumar sir. May I invite sir for the presidential address.
Yeah, good evening all. Respected Singaravelu sir, today's speaker Nitin Shah sir, Dr. Jose, Dr. Johnny, Dr. Riaz, Dr. Nandish, and seniors, Dr. Srinivasan sir, Dr. Parvati madam, other my dear friends. At the outset, let me congratulate our team led by Dr. Johnny Sebastian for the excellent action plan Back to Basics. The first talk was well appreciated by pediatricians across Kerala and even outside Kerala. Then today, it is our second session. We are going to discuss ABC or CBC. As you all know, CBC is the most commonly asked investigations and unfortunately most underinterpreted and overinterpreted misinterpreted investigation, I can say. And with meticulous reading and if a very quality CBC report, we can diagnose many conditions and we can rule out many serious conditions and we can avoid going for much costly investigations. To discuss this, we have none other than the doyen of pediatric hematology in India, Dr. Nitin Shah sir. So we'll enjoy his talk and have a happy learning. Thank you. Thank you all.
Thank you, sir. We have our guest of honor, Dr. Shingaravelu sir, who doesn't need any introduction to the IAP fraternity. Former Dean and Head of Department of Pediatrics, Government Medical College, Tanjavur, and currently at Vinayaka Mission Medical College. He has 41 years of teaching experience and that of mentoring young pediatricians. Sir was the National IAP Vice President in 2024, and he is the National President-elect 2026. May I invite Sir to address the gathering.
Thank you. Thank you, Dr. Sweta, for your nice introduction. At the outset, I should thank our chairperson of this B2B, Dr. Johnny, my good friend, and our respected president of Kerala, Dr. Nandakumar, and immediate past president, Dr. Riaz, secretary Gobi, and treasurer Binu, and president of National IAP, vice president and president of South Zone, Professor Joe sir, and my mentors, Dr. Srinivasan sir, and Nandi sir, and Ramesh Bajania, and Bala, and so Parvati ma'am, and so on. If I start telling, everybody is known to me. And at the outset, I thank the Kerala team because they are always very affectionate with us and with me, and particularly, and I have been together in all the programs as the vice president. And I thank for giving me this opportunity. And today's program, none other than you have properly chosen a person of great academics. Not only he is an academician, he is a great administrator, and he is one of the main pillar of our national IAP, who is a guiding force for all the past presidents. And I am sure that he will be my guiding force for future, my tenure also. Sir, surely, and your academics and your administrative knowledge, and it is well known. When Nandakumar was telling 40 people have joined, now it has crossed 80. By the time I finish, it will be fulfilled because, and I should be thankful to Ramesh Bajani also here, because the way he utilized Nitin sir and how we all spread the knowledge to the practicing pediatrician. It is the more important, and sure that I should appreciate Johnny and the team led by all the zonal Jijo, Amira, and Sweta ma'am, and all those who are involved in that, bringing the first program with Nitin sir. Definitely, it will be the very useful and very practically very basic. Actually, as you put as a B2B, which last year as a scientific advisor, we were doing at Tamil Nadu. And now it is being carried out in the form of rainbow. And I was there when inauguration installation of Dr. Nandakumar, and the way he presented his action plan was wonderful. It was at par with the national AP. So we are learning from you, Nandakumar sir. And today's topic, I don't want to take much time because people are very eager. I just want to fill that so that Zoom platform should be full. That's why I'm just extending for a few seconds. That's all. With this, I'm very thankful to the entire team of Kerala under the leadership of our Dr. Nandakumar and his team, and our Riaz sir. The amount of help Bala and others have done for me, particularly Jijo and everyone, Meera. I can go on adding everybody. The whole team of Kerala was behind me for my entire this thing, and I will be grateful to them. With this, I thank and wish that this B2B, when it was even begun by our national past president, Dr. Nitin Shah sir, surely it will be a very hit in future. In the throughout this year, all your academic program will go on very well, and happy learning, and wish you all the best. That all knowledge should go to not only to Kerala, it will go to the whole India. Surely people will be benefited. Please record it and keep it in your, so that it should be easily available to all people who are, whenever it is needed. With this, I'm very happy to be part of the program and made me as a guest of honor. Thanks to the entire team. Over to Madam Sweta. Thank you. Thank you.
Thank you so much, sir, for your supportive words. Now, may I invite the distinguished, revered, and luminary in the realm of pediatrics, our own Dr. Jose Osa, South Zone Vice President of National IAP. May I invite sir to address the gathering.
Thank you, Dr. Sweta. IAP Kerala State President Dr. Nandakumar. Today, the guest of honor, Dr. M. Chigaravulu, the President-elect. For the chairperson of this Back to Basics, Dr. Sebastian. And all the conveners of the program, Dr. Jijo, Dr. Sajana, Dr. Parvati, and all the teams of IAP Kerala. Our State Secretary, Dr. Gobi Mohan, Professor Dr. Binikutan, our past president of IAP, Dr. Riaz, incoming president Dr. Balajandar, and our past presidents are Dr. Parvati Madam, Dr. Jayaraman sir, Nandesh, and Dr. Srinivasan sir, and all my friends, and good evening to all. It is an honor to me attend the inaugural function of this second section of Back to Basics. As Dr. Nandakumar is mentioning, this is the basic of the updating the knowledge is very important of our pediatrician and day-to-day practices concerns. So that's why the Nandakumar is charter out this action plan Back to Basics, starting the second edition. I think today the faculty, none other than our past national president of Central IAP and doing the hematology, Dr. Nitin Shah sir. I think IAP Kerala is very honored, very lucky to have the time for Dr. Nitin Shah to talk on the topic of CBC and the basics of CBCs. I think this is very important topic for our pediatrician to know basics of our CBC interpretation. We are witness so many times the Nidisha talk on CBCs. Every time there will be new information will be there. I think this program is also going to enlighten our pediatrician regarding the back to basics of CBCs. Again, Dr. Nandakumar in his action plan Rainbow, I think in his action plan, almost 60%, more than 60% action plan now it is rolled out. I think every action plan very much appreciated by the APNs of Kerala and all outside of Kerala are very much appreciated. All the action plan, including academics and non-academics like financial issues, programs. I think that is very keen for the flagship program for Nandakumar. I congratulate the Nandakumar and team for initiating this Rainbow Action Plan and enlightening all the IAPNs regarding the academic and non-academic program. I wish you all the best program. Jai Hind, Jai AP.
Thank you, sir. Now may I invite the vibrant Secretary of IAP Kerala, Dr. Gopi Mohan, sir, for the felicitations.
Respected AAP Kerala President Dr. Nandakumar, guest of honor Singarvelu sir, our Vice President of South Zone Dr. Jose, my good friend Johnny, other coordinators, seniors, other dignitaries and our friends. I don't want to take much of a time. Everything has been covered by the luminaries before me. I wish this program a great success, and I hope that we will continue this program next year also. With these few words, I wind up. Wish you all a happy learning.
Thank you, sir. Now, to propose a vote of thanks, may I invite Dr. Sajna Said, North Zone Coordinator of Back to Basics PAP.
Good evening, all. First of all, I would like to thank our State President Nandakumar sir for the presidential address. My heartfelt gratitude goes to our National President-elect Singaravelu sir for gracing this program Back to Basics, second episode. And I express thanks to our esteemed speaker, Nitin Shah sir, who's gonna break down the complexities of deciphering this complete blood count, making it simple for practicing pediatricians. Next, I thank our dear Central IAP South Zone Vice President Joe sir for being here today. I also thank our chairperson Back to Basics, Dr. Johnny Sebastian sir, and Dr. Shweta for being the MOC and the convener. And I thank all the senior leaders in the platform for being here and all the audience for making this program a success. Thank you all.
Thank you, Dr. Sajna. Now we have crossed the 100 minutes of our Zoom.
Shweta, what I told in the beginning, what I told.
Yes, sir.
Thank you.
So may I invite Dr. Jijo, Central Zone Coordinator of Back to Basics PAP, to introduce our distinguished speaker.
Thank you. Good evening, respected seniors and dear colleagues. Good evening, Singarvelu sir, Jose sir, and all my dear friends and our senior leaders. It is a privilege to have with us Dr. Nitin Shah. Sir is one of the most experienced pediatric hematologists who has more than 34 years of clinical experience in pediatric hematology and oncology, practicing at reputed institutions including Hinduja Medical Research Center and Apollo Hospitals. He's a professor at Wardia for FNB Hematology, He has been the president of IAP in 2006 and is a fellow of the Indian Society of Hematology and Transfusion Medicine. Sir is a teacher of teachers. A very complex topics of hematology are simplified by Sir, and the clinical context is of absolute use to all the practicing pediatricians. We're delighted to have you with us, sir. And I'm confident this session will deepen our understanding of CBC interpretation, as everyone told. With great pleasure, I now invite Sir for his talk.
Sir, one suggestion. Somebody has joined in two devices. So, sir, lecture will be disturbing. Please, those who joined in two, please switch off. It is. Thank you, sir.
Okay, sir. Sir, it is in YouTube also, sir. Okay.
Thank you, everyone. First of all, it gives me immense pleasure and honor and pride to be part of this Back to Basic series, started by one of the most vibrant branches of the IIP Kerala branch, not only now, but for years since the time I have joined IIP. And what better platform than when my dear friend Dr. Singar Velu is the guest and guest of honor. And I can tell you, I mean, of course, all of you would know, but I have interaction with him. He's a president who is the most humble, most grounded, and absolutely simple president. He's going to really make history when he takes over next year. And I'm sure he will have a absolutely fantastic year and years to come thereafter. And people will remember not only him for his simplicity, but also his program, which I'm sure he's in the process of making, finalizing. And what to talk about Dr. Srinivasan? He's always there in all the programs. I really don't know how much he gets the energy to listen to the same crap that we talk again and again, sir. Thank you. Thank you for being present here. All the dignitaries, all the office bearers of the IIP Kerala, all the past president of IIP Kerala, all those are involved with this Back to Basic series. My dear friend, Dr. Ramesh, and all of you, I bring greetings from Mumbai. And now I will start sharing the slides and I'll start my talk. What I'm going to do is, 1 minute. Yeah, you are able to see it, right?
Yes, sir.
Yes, sir.
Right.
Yes.
So what I will do is I will discuss this ABC of CBC in the form of 10 or 12 cases, because that makes it a real-time experience rather than just talking theory about how to interpret this and how to interpret that. And discuss counters and how they work and all that will be very boring. So I'm going to start with the cases. Before that, this is the type of CBC report that you should have at least in difficult cases or in patients with hematological conditions, anemia, etc. Ideally, every CBC should not be from a counter, because the counter gives you reproducible report, which is very quick, which is very reliable, and it gives you a lot of information besides just the basic the parameters like hemoglobin, WBC, platelet, etc. It tells you about every series, what is wrong with the series. And some of these latest counters also have red flags, which tells you that you need to look at the red flag and dig into more about the CBC and the smear. And it actually gives you a lot of clue about abnormal cells, about malarial parasites, and so on and so forth. So when you see this type of CBC report, you should interpret it cell line by cell line. So when I call cell line means like hemoglobin or RBC is one cell line. So you look at the hemoglobin level, look at the RBC count, look at the RBC indices, the mean corpuscular volume, the mean corpuscular hemoglobin, the hemoglobin concentration, MCHC, and most important, RDW, the red cell distribution width, which gives you a clue about how are the RBCs present in the body. Are they of the same size and shape, or are they different size and shape? So after having looked at the RBC series, next you look at the WBC series. And I think most of the pediatricians pass the WBC as normal when they see total count is normal. It is not that only total count that matters. What you should calculate is the absolute neutrophil count, or the ANC, and the absolute lymphocyte count, or the ALC. Both are very important. Just to give you an example, if you have a newborn who is otherwise completely okay, and you see his WBC is 10,000 with 20% lymphocyte, most of you would pass it as normal, whereas that 20% lymphocyte makes absolute lymphocyte count of only 2,000. And when you have an ALC of 2000 in a newborn, that's a catastrophe. That is SCID, or severe combined immunodeficiency, unless proven otherwise. So like that, suppose you have a child with a lot of cough and cold, and your counts are 9,000, but you see 90% lymphocyte. There could be blasts because the blast may look like lymphocyte. Or you may have someone with 60,000 WBC with 80% lymphocyte. That may be pertussis in a child who is coughing. So you need to calculate what is driving the WBC count high or low by calculating ANC and ALC. Now, having done the WB series, the next is the platelet series, where you look at the platelet count. You also look at the mean platelet volume, which gives you the size of the platelet, because you know large platelets are usually regenerative, like in ITP patient, whereas small platelets are regenerative, and a very small platelet, like tiny dust-like platelets, are very typical pathognomonic of Viscount-Aldrich syndrome. So from this itself, you can make the diagnosis of a Viscount-Aldrich syndrome. And many counters today will also give you a retic count, which is like the window to the bone marrow as far as RBC series is concerned. And it also gives you what we call immature platelet fraction or IPF, which is a window to the marrow for the megakaryocytes of the platelet series. So this completely makes into one CBC interpretation. And last but not the least, we never look at the bottom of the report where you see these beautiful histograms. Those histograms actually tell you how are the platelet, RBC, and the WBC disperse in your body. So it will tell you the width of, like, the size of the RBC, size of the WBC, and so on and so forth. So when you have a difficult case, just don't look at the count, hemoglobin, WBC, platelet, but you need to actually look at this different parameter that I spoke about. Now let's see how we put these parameters interpretation in actual practice. So as I said, always look at CBC cell line by cell line, all the three cell line one by one. Then you put them all together. That will tell you which cell lines are at fault. Is it single cell line, two cell line, three cell line? That will tell you whether marrow is at fault or marrow is not at fault. Last but not the least is CBC also includes a peripheral smear. If someone tells me that I can do only one test in a child with anemia or abnormal count, which is the test? I will do only peripheral smear myself, stain it and see under microscope. Because what peripheral smear gives you is a plethora of information that you cannot get from any other laboratory. Just to give you an example, I get patients with weight counts, little fever, not doing well here and there. They've done some 3-4 CBCs at different places, and no one has seen the smear properly. And they come to my clinic. I just take a fingerprick smear, see it under micro, and tell them there are blasts. And they get worried. We have done 4 CBCs, no one told there are blasts, and you are saying this child has leukemia. So they won't believe. So that much information actually you can get from looking at the peripheral smear. So a good CBC on an automated counter, a good peripheral smear by trained eyes, and a retic count and immature platelet fraction added to this will give you 9 out of 10 times diagnosis as to what is wrong with your patient. So let's start with the first case. This child is, of course, pale. As you can see, she's malnourished also. And I've purposefully put the foot rule of the ideal height for her age. And you see actual height, there's so much of difference of almost more than 10 to 12 inches. And you can see on the right side, her hands, which are showing platynachia. So when you have platynachia, which is flat nail, or koilonychia, even worse, a spoon-shaped nail, is very pathognomonic of iron deficiency anemia. Though it is not seen in children very commonly, it's more in adults, especially in females. But if you see it in a child, that usually clinches the diagnosis of iron deficiency. So you always collaborate your clinical finding with CBC to become more smarter. So this 8-year-old female child has come with pallor for last 3 years, off and on. She's had diarrhea off and on. She hails from Rajasthan. She was treated with iron, but she would not respond as you would want for the pallor. When she came, she was, of course, looking pale and stunted and undernourished, as I showed you. There was no hepatosplenomegaly or lymphadenopathy to suggest any sinister disease. And this is the CBC with she comes. Now let's look at my principle. First RBC series, hemoglobin 4.5, gross anemia. Now that gross anemia, and she's so comfortable in the picture, which means this is a very chronic anemia. If you drop from 12 gram to 4 gram in one day, you will drop dead. Whereas you drop from 12 gram to 2 grams over 6 months, like walking iron deficiency, you will be completely asymptomatic unless you have exertional dyspnea. Now, what is driving that hemoglobin low? Look at the MCV. What is the size of the RBC? MCV is 56, which is very low, which is microcytic. Okay, how much is the hemoglobin content in the RBC? 20 picogram, very low. Normally is 28, 29. So it's hypochromic. So she has got severe anemia, which is grossly microcytic and hypochromic. Now, when you have this type of anemia, you are worried whether it is iron deficiency, whether it's thalassemia minor, what is it? So you look at the RDW, red cell distribution width. RDW is 25, normal RDW is 11 to 13. So this is very high. So that means the RBCs are of different sizes on the smear. Now you like to confirm that RDW which is high, what is the anisocytosis by looking at the smear. And you can see the smear is very severely showing micro, hypo and aniso. So now you have confirmed everything on a smear. Because this child was treated with iron and not responding, you will want to do iron studies. If this child was 2 years and coming for the first time, I will not do anything, just give them oral iron and follow up for the next 3 months, and his hemoglobin, everything should become normal. But because the child is not responding in the past, I will want to prove the iron status by doing iron status. Now, when you in children, you never do serum iron TIBC transferrin saturation because they are very dependent on the diet and the day when you do. So the best is the iron store in the body, which is ferritin. See, someone who doesn't have fever, ferritin is a good source. When there's someone has fever, ferritin will be high as a acute phase reactant. But when the ferritin is low, like this, 2 nanogram, is like virtually no iron in the body. So now look at the so we have now known severe microcytic hypochromic anemia with high RDW looking like iron deficiency, proven as severe iron deficiency. Okay, believe it there. WBC series, normal WBC, normal polymorph lymphocytes, so normal absolute neutrophil and absolute lymphocyte count. W series is normal. Platelet count 4.5 lakhs. If at all, little higher, so it's normal. Next is retic count 1.2%. That 1.2% looks normal, but you have to correct it for the hematocrit. Now, this child, the hematocrit will be around 12 to 13 or 14, which is like 1/3 of the normal hematocrit, which is 45. So you divide this retic by 3, it becomes 0.4, which means the retic is only 0.4. The marrow is not working. Now, marrow may not work when the marrow is diseased or the marrow doesn't have the micronutrients to make RBCs. Now we know the marrow doesn't have iron. So she's not making iron and she's got iron deficiency like picture. But and you confirm by peripheral smear. You can see this very like the empty cells, so severe micro, smaller cells, severe hypo, and you see ovelocytes. So like pencil-like cells. So micro ovelocytosis is very typical of iron deficiency anemia. So she has got iron deficiency, but not getting treated. Now there are two clues. One, she's 8 years. Why would an 8-year-old child have nutritional iron deficiency? Number two, if she has iron deficiency, which is nutrition, why is she not responding to oral iron? And number three, by all this, why she remains so stunted? And there's one more history. If suppose the child had like needing transfusion once in a while, 2-3 times in the last few years, no iron deficiency child would need transfusion. So these are the point to say this is not nutritional iron deficiency. So you need to find out secondary cause of iron deficiency anemia. So you look at the bleeding, like in the GI bleed, so you can Meckel, polyp, anastomosis, ulcers, malformation, or she's not absorbing like celiac, tropical sprue, worms, ulcerative colitis or IBD. All that test you'll have to do. So first thing I will do in this child who has got ancestry from Rajasthan, which is very, very typical. Celiac disease is very common in North Indian ancestry, but we see because of migration, these people also coming to South and West. So we do our NT-T3G, which is positive. You don't have to do all the three. I've just put them on for the record. All you do is NT-T3G as the screening test. The only place where I know you do anti-gliadin antibody is in a patient with autism, where sometimes they can have not celiac disease, but only gluten hypersensitivity. And such children, you put them on gluten-free diet, their autism disappears. So that's one thing you should keep in mind. Now, two thoughts. Gastroenterology will always say, do a duodenal brush biopsy, prove there is bilious atrophy, put the child on gluten-free diet, the child improves, and you again repeat a biopsy and show that the villi have come back. Many people are not ready to undertake all this. So what they do is they put them on gluten-free diet and look at the response in CBC and in the weight and height. If everything drastically responds, you know you have treated a patient of celiac disease. So 8 years is not the age for nutritional cause, and there were other things which were not fitting into. So the diagnosis celiac disease made right from the CBC itself. So what are the differential diagnoses of a microcytic hypochromic anemia? Iron deficiency is the most common cause. anemia, chronic inflammation, either alone or in combination with iron deficiency. Most of our children have a lot of recurrent cough colds, so they also have both iron deficiency and chronic inflammation. Then they can have thalassemia minor. So high risk communities, Sindhi, Punjabi, Kutchi, Luana, Banushali community, Devegowda, and usually they will have borderline low hemoglobin, but a very low MCV and a high RBC count. And lastly, sideroblastic anemia, though we see rarely, but once in a while we see such patients. So RDW is a very important test to interpret any anemia, especially microcytic hypochromic and macrocytic anemia. So RDW is nothing else but the coefficient of variation in the red cell volume distribution. So when you have anisocytosis, small cell, large cell, ovocyte together, that will push the RDW to higher side. In this child, it was more than 23. So how do you interpret RDW and anemia? So this is a very important table. You have low MCV and high RDW like in our child, iron deficient anemia. Suppose you had low MCV and a normal RDW, especially in a setting of a high risk community, thalassemia trait. You have high MCV and high RDW, it will be megaloblastic anemia. Your high MCV and normal RDW, it is either a bone marrow disease or a liver disorder. So all high RDW is nutritional cause and all normal RDW are non-nutritional cause. I think this is simply so simple to remember. Now just point, how do you treat iron deficiency? So you give oral iron for 3 to 6 months. So you should continue oral iron for at least 2 to 3 months after hemoglobin become normal. And it takes almost 1 to 3 months for the hemoglobin to become normal. Deworm the child, diet modification, stop the bottle, treat the mother if the child is on breastfeed because she is iron deficient, she will not give the child enough iron. When you suspect secondary iron deficiency, like in this child, not primary dietary, so age more than 2 to 5 years, systemic symptoms and signs of other disease like in this child, stunting, non-responder, or anyone needing transfusion. How many days you send stool for occult blood when you suspect GI bleed as a cause like polyposis? 5 days. 1 day is not enough because GI bleed doesn't happen every day. So if the 5 day stools are normal, then it tells you that it is not because of the GI bleed. All right, we talked about thalassemia minor as a second differential. There are certain communities which have a particular type of hemoglobinopathy. As we don't have an active audience participant here, I will just say that thalassemia is more common in Sindhi and Punjabi, of course. Sickle cell is more common in tribals. G6PD is more common in Parsis and Banushali Kutchi community. Hemoglobin D is typically seen in Punjabi, but remember hemoglobin D disease itself doesn't lead to anemia. Is only when it is compounded with either a thalassemia or E, then it becomes a symptomatic, or with sickle. And lastly, hemoglobin E. E stands for Eastern. So you can, hemoglobin E is seen in patients who are from Eastern side, that is Bengal. All right, so this is how you look at the community and the type of anemia. Let's switch to the second case. 5-year-old male child. What I'm showing you here is on the right side, one child having a completely shining tongue, bald tongue, and some pigmentation. Normally our tongue is furrowed, whereas this is completely shining bald tongue. On the left side are other patients of similar disorder where you can see a very classical, what you call a hyperpigmented knuckles. So there is so much of hyperpigmented knuckle and sudden cutoff. So you can see the difference in the color at the edge of the knuckles. So this is both in hand and in the leg. All right, so 5-year-old male child, pallor since 2 months, fatigability since 1 month, jaundice for 15 days, and recurrent stomatitis. Now something progressively increasing in the severity. When you have jaundice in a child with anemia, ask whether it's associated with dark urine, choleric, which is more liver disorder, or no choleric, not dark urine, only like yellow eyes, acholeric. It is indirect hyperbilirubinemia. So direct jaundice, dark urine. Indirect acholeric because of some hemolysis or ineffective erythropoiesis. Nadisha was pale, was icteric, had stomatitis, and no other organomegaly. Now again, let's come back to CBC, which is our today's focus. Hemoglobin is low. What is driving the hemoglobin low? Look at the MCV. MCV is high, 110, more than 90 or 95 is high. Next, look at RDW. I say nutritional RDW is high. RDW is 26. We made a diagnosis. Severe anemia, macrocytic, high RDW, nutritional. With that picture of bald tongue and hyperpigmented knuckle, the diagnosis is made clinically. You don't have to do any further tests. All right, you look at the WBC count. WBC is low. Now we are worried. Is it leukemia? Platelets also are low. We are worried. Is it leukemia? Now you look at the smear. The smear is showing you macro 2 plus, ovalo 1 plus, which means confirming your diagnosis of macrocytic anemia with high RDW. Why are the other cell line down? So remember, in a megaloblastic anemia, it's not only the RBC series which is affected, but also the WBC series and the platelet series affected, but not to that extent that will happen in a bone marrow failure like aplastic anemia or in leukemia. So let's interpret. We said icterus, which is acholiuric, uh, macrocytic hypoanemia with borderline low ANC and a borderline low platelet. What further chemical test you can do? You do bilirubin to confirm it is indirect. You can see it's all indirect. Do LDH, which is very high. Retic, which is low. So marrow is not working. With high LDH in such a child, the diagnosis made megaloblastic anemia. And all I want to do is peripheral smear. Look at the macrocyte, ovalocyte, and as I call my friend, this is what is known as hypersegmented neutrophil. Any neutrophil which has more than 5 lobes, or you see more than 5 neutrophil with 5 lobes, it is very typical of a megaloblastic anemia. So let's come back to our RDW and the chart. You have this child has high MCV and high RDW, megaloblastic anemia. Previous child had low MCV, high RDW, iron deficient anemia. So simple to interpret CBC in this type of picture. So you look at the smear, it shows you macrocytic picture. You may see Howell-Jolly body. You can see basophilic stippling, as you can see in the bottom two smears. And on the right-hand side upper, I showed you a hypersegmented neutrophil. We don't do bone marrow in children because usually it is nutritional. We don't even work up for pernicious anemia because nutritional in cause. But if you have an adolescent with other autoimmune feature like diabetes, joint problem, alopecia, or vitiligo, then you will like to rule out pernicious anemia, especially if they don't respond to oral B12, and then you can do the anti-islet and antiparietal antibody. But we have rarely done that in pediatric patients. And marrow I don't do, but if you do the marrow, this will show you what is known as typically megaloblastic anemia, a large erythroblast, which has an open sieve-like nucleus and a very dark blue cytoplasm. And next to that, you can see a giant metamyelocyte. So this is very typical of megaloblastic anemia. Okay, again, name 4 common causes of very high LDH. So we said one was megaloblastic anemia, second is malignancy, leukemia, lymphoma, third is HUSTTP, microangiopathic hemolytic anemia, and lastly HLH. Basically, these are the conditions where there is a very high cell turnover. Okay, third case. So we saw one microcytic, we saw one macrocytic. Now, a very small child, 15 months male child, pallor for 4 months, abdominal distension for 1 month, born to consanguineous marriage. Now, consanguinity in any condition, especially hematological and neurological condition, is very important because it tells you there is some autosomal recessive condition probably. All right, community, we already saw tribal. Mahar is a tribal community. So Mahar community, now we are getting more and more clues on history itself. No fever, no weight loss, no transfusion. It's come with failure to thrive, gross pallor, and icterus. Again, ask choleric or acholiuric. This was acholiuric, so indirect hyperlipidemia. Here, gross hepatosplenomegaly, huge liver, huge spleen, and no lymph node. And this is the CBC. Again, hemoglobin is 3.5. What is the MCV? 75. Not that low. Okay. WBC 60,000. That's very high. Low polymer 20 and high lymphocyte 80. You're worried about leukemia because I said you are high lymphocyte, you're worried about leukemia. But the platelet count is 4.3 lakh. So this shall be referred to rural leukemia. Now, what do we have? We have someone from Mahar community who has got gross hepatosplenomegaly with a very low hemoglobin, but a normal MCV and a normal MCH, a little low MCH, and a high WBC count. But if you look at the absolute neutrophil count, is 12,000. That is normal. And platelet is 4.3 lakh. That's normal. You can't have leukemia with such low hemoglobin and gross hepatosplenomegaly and with normal ANC, normal platelet. So without looking at the smear at the CBC cell, I can tell you this is not leukemia. Then what are those WBC? Why the WBC is so high? So we see the smear and they are all nucleated red cell or the RBC precursors in the peripheral smear. Now your counter counts all nucleated cells as lymphocyte or WBC. So These are not WBC, but they are NRs or nuclear red cell, but they are mistaken by the counter as WBC. That's why it's giving you a spuriously high. So you correct your WBC count by looking at how many RBCs per 100 WBC. So this child had more than 200 nucleated red, how many NRs per 100 WBC? So this child had 200 nuclear red cell per every 100 WBC. So you have to actually calculate this WBC count by 1/3. So it becomes 20,000, which is normal. All right, so you order for electrophoresis. Your HbF is 90%, which is very high. So it is thalassemia major, and you treat the child as any thalassemia major. Two things you will want to do: look at the parents, they both have to be minor. Look at other siblings, whether they are minor, major, intermediate, whatever, and counsel them for the future pregnancy if they are planning for future pregnancy. And you have to do this counseling not only for this family, but extended family, both on the mother and father side, because their brother, sister can be minor and they can have children which are minor or major. So other smear diagnosis in hemoglobinopathy is this child has come with painful swelling. Very small child has got painful swelling of the hand. Somebody thinking of osteomyelitis, the hemoglobin was low, so reference was 7. And you can see the CBC shows pencil-like cell and nucleated red cell. So this is sickle cell anemia. This is hand-foot-mouth syndrome. Now, hand-foot syndrome of sickle cell disease. All right. So how do you treat sickle cell disease? Hydroxyurea. Start with 10 mg. You can go up to 40 mg per kg. When do you start? As soon as diagnosis is made, and you continue lifelong. How does it work? It increases the hemoglobin F level, which protects against sickling and ameliorates the symptom as well as need for transfusion. All right, one more hemoglobinopathy which you can start diagnose on a CBC. If you have a counter report. Now, I'm sure this is a big report. You may not be able to see very clearly. I'll put underline. This child's hemoglobin is low, 8.7. Now, what is the MCHC? MCHC is something which you never look at. 41.8, that is very high. Anything more than 30, 32 is high. Okay. This child's diagnosis is made. He has come with anemia of splenomegaly, and this is nothing else but you see the smear and you see the spherocytes. This is congenital spherocytosis or hereditary spherocytosis. Again, I'll show you. You have a high MCHC, low hemoglobin, mild splenomegaly in a child who has got smear showing spherocyte. Diagnosis is spherocytosis. Some more smear which clinch diagnosis. These are all target cells. If you see too many of them, you see them in either liver disorder or in hemoglobin C disease. So that's how you make diagnosis on smear. All right, case number 4, 10-year-old male child. He's chalky white. You can see his nails are so pale and he's got puffiness in the face. So he's got pallor since last few months, breathless since 20 days, puffiness and edema fit since 5 days, progressively becoming more sick. He was pale and puffy without any organomegaly. Now this is the CBC. Hemoglobin is 6, moderate anemia. What is driving the CBC? MCV 88, absolutely normal. MCH 28, absolutely normal. RDW 12, absolutely normal. So normocytic normochromic anemia. Now retic is 1%, which if you correct for the hematocrit is less than 0.5. So again, the marrow is not working. Look at the WBC and the differential normal, platelet normal. Single cell line RBC series, which is normocytic normochromic. This is not nutrition anemia. Do not waste your time in giving them tons of hematinic. This is some systemic disorder. You need to look at the child more carefully and maybe refer them in time rather than passing time or giving them unnecessary transfusions. So I look at the smear, I see all the platelets are normal, there is normocytic, normochromic, and I also see good polymorphs, so WBC is normal. So we have a absolute normocytic, normochromic anemia in a child who is becoming breathless. Now his breathless was ascribed to anemia. But why should he be having edema feet? Now that was completely missed. The next thing I do is a clinical test, and that is taking the blood pressure of the child. So when I took the blood pressure, it was sky high. I did his creatinine, it was 4.5. This child was chronic renal failure. Many times patients of chronic renal failure come to us for anemia rather than with the urinary symptom. And he was breathless because he was acidotic and not because he was pale. So how do you look at the normocytic normochromic anemia? First look at the retic. Usually if it increase is because of hemolysis. Normally it is normal or decrease. Look at the marrow. If it's abnormal, all marrow disorder. If the marrow is normal, then all systemic disorders. So you do liver function test, renal function test, ferritin, you do CRP, like how we did in this child, creatinine, and so on and so forth. All right. Now name two biochemical laboratory tests that you do in a suspected case of malignancy. One we saw was LDH, other is uric acid. Now these are very important tests which will help you. If they are low or normal, it virtually rules out an aggressive malignancy like leukemia. All right, we move to the fifth case. 1-year-old male child, mother is holding the child. Mother is quite pink. She's showing her hand, and you can see the child is very pale and irritable. So sudden onset of pallor and puffiness in the child for 1 day, jaundice and dark urine. Now, when you have dark urine, there may be various causes of dark urine. So you need to ask the mother, is the color like haldi? That's more like liver disorder. Is it more like cola, thumbs up color? Then it's more like hemolysis. Or is it absolutely red, which may be hematuria? Or it is pinkish, which may be because of fruits like dragon fruit or beetroot, which is eaten by the children. So these are the ways you will differentiate the color of the urine. He had fever and cough 7 days back. So now I have virtually made my clinical impression as to what's wrong in the child. Acute anemia, making the child puffy and having dark urine and preceded by a URI-like picture. Okay. He's pale, he's icteric, he's puffy, he's breathless, his spleen was 3 centimeters. That means that anemia is already leading to splenomegaly. Now this is the CBC. Hemoglobin is 6.5. MCV is 100. It is high. Now WBC is 18,000 with normal differentials. That's normal. Platelet is 256,000, which is normal. We have confirmed that he's got indirect hyperbilirubinemia because his bilirubin is 4.3 with direct of only 0.5, and his retic is now 8%. Now, even if you correct it for his hematocrit, the retic is still 4 or 4.5%. That's high. So acute onset of jaundice with dark urine, with splenomegaly, and reticulocytosis with indirect hyperbilirubinemia. There is only one diagnosis. He is hemolyzing 100%. So when I go for round, I ask them to show me the color of urine that the child passed overnight. Don't throw it or keep it. On the left hand side is the normal color urine in the bottle, and the right hand side is what the child passed. Absolutely thumbs up or cola like color. Next, I see the smear. I see some microspherocytes, some basophilic stippling, and you see polychromasia, which means there is acute hemolysis. And I see one NR, which means the marrow is responding. On your right hand upper side, I see that there are retic count is very high. I confirm it by the retic preparation. And the left hand side bottom is the most important smear. I see lot of rouleau formation or clumping of the RBC. Now my diagnosis is 100% made on this. This is nothing else but AIHA or acute immune hemolytic anemia. So you do a urine, blood is positive, but RBC are not there, which means all hemoglobin. You ask for the direct test, it's positive. In child had cough and cold, so it's more likely to be IgM, maybe mycoplasma induced IgM antibody, and all you need to do is just supportive child, no need of steroid, and the child will be okay. Now, how many of you, when I showed you the CBC, looked at the MCHC? Can you see the MCHC is 80? What is the normal MCHC? 30 to 35. We saw in the child with spherocytosis, it was 45. 80 is very high. Now that's because these clumped RBCs are taken as one mass by the counter, so it makes a mistake. When you see very abnormally high MCHC in a patient like this, again that diagnosis that this is acute immune hemolytic anemia. So AIHA, IgM, no treatment, just supportive. IgG, yes, steroids and or rituximab. Okay, some more smear in hemolysis. This is a bite cell, okay, like a bitten apple. This is typical of a G6PD deficiency. Okay, this is a smear which is showing you polychromatophilic blue, large blue cell, some spherocytes, and you see no platelets. And you see broken cell like helmet cell or very broken cells. This is typical of microangiopathic hemolytic anemia, what we call schistocytes in a patient with HUS. If you see grossly acanthocyte, this can be either because of renal failure or liver failure. All right. Case number 6, 4-year-old male child. He is showing you he has got lymph node in the posterior part of the neck, posterior triangle, and some which is post-auricular. All right. 4-year-old child had fever for 15 days, moderate without any rigors. Cough for 15 days, no breathlessness. Loss of appetite, but there was no weight loss. Now he has this significant lymph node. Now what is a significant lymph node? Any axillary lymph node more than 0.5 centimeter, any cervical more than 1 to 1.5 centimeter, any inguinal which is more than 1.5 centimeter, any abdominal more than 1 centimeter, any thoracic which is more than 1 centimeter. Any lymph node which is tender, which is tethered, which is firm like rubbery, or has a discharging sinus, or has got matting is significant. So this is a significant lymph node by its size. Now this is the CBC with which it comes. Hemoglobin is 11 with normal indices. So RBC series is normal. What bothers the pediatrician is the WBC count, which is high, and there are some abnormal cells as reported by the pathologists. There are some metamyelocytes, there are band cell, myelocytes. So he's worried, is it leukemia? And his platelet is 8 lakh. Now let's interpret this CBC. So it's not leukemia. Why? Because number one, he's got normal hemoglobin. Number two, he has got high platelet, which is more like a reactive marrow. Number three, though his WBC is high, his neutrophils are 35, which makes the ANC of 12,000. So that's marrow is working. In fact, marrow is overworking by throwing away cells which are like precursors like myelocyte, metamyelocyte, band cell. So this is an irritated marrow because of fever, whatever causes, which is leading to what you call shift to left or a leukemoid reaction and not leukemia. Okay, so leukemoid reaction with leukemia is no, you will have normal ANC, normal platelet, and there'll be no blasts in. Leukemoid reaction versus CML, again in CML, the counts are more than 50,000. In leukemoid reaction, is usually below 50,000. And you see a lot of basophil and promyelocyte besides some blasts in a patient with chronic myeloid leukemia as compared to leukemoid reaction. What are the common causes where you see leukemia reaction? Many. Infections, tuberculosis, hemolysis, hemorrhage, metabolic, so on and so forth. So you'll have to do workup for all this child. This child, of course, turned out to be tuberculosis, one a biopsy, and he was treated with AKT and everything started becoming okay. All right. A small male child with gross hepatosplenomegaly. So high fever for 15 days, off and on, no rigors, some loose stools. There was past history of repeated fever. That means the child is sick in last several months with having these bouts of fever. He was having that gross hepatosplenomegaly and he was sick looking, like irritable. There was nothing else like no lymph node and he was little pale. So CBC was done which showed hemoglobin of 8 gram, normocytic, normochromic. So again, RBC series is not because of nutritional cause. WBC is low, 2600 with normal polymorph and normal lymphocyte distribution, and the platelets are again low, borderline 1.1 lakh. So there is some mild pancytopenia in this child who has got fever off and on since last few months. So is it leukemia? Again, the answer is very unlikely. Of course, I will see the smear for blast, but I will do serial CBC rather than doing a marrow at first place. So single cell line defect, ANC is near normal. Common causes will be typhoid, malaria, TB, malaria, Kala-Azar, viral infection, which will come like the HIV in the past. Now, of course, we don't see too many drugs. Cephalosporin, your sulfur drug, all can precipitate temporary marrow dysplasia. Treat the infection, repeat the count. If they become normal, fine. If they don't become normal, do marrow. But interim period, don't give steroid, don't give blood transfusion. This child, of course, the smear showed that he had multiple ring form on the RBC, and on the right side is showing gamete, which is banana shape. So this was falciparum malaria. All right, now a sinister case. 3-4-year-old child is showing you the neck, which is full of lymph node. His liver spleen, which is grossly high, and he's got inguinal lymph node, and someone has done an inguinal lymph node biopsy under ultrasound guidance. But they did not strip the child, and they missed the very important finding: testicular swelling on the right side. This is clinical diagnosis of leukemia. Don't mess around with this child with anything else, and especially don't give them steroid or blood transfusion. So if this child is very sick, 15 days fever, weight loss since 1 month, leg pain. Now, when you have leg pain, is the child awakening with leg pain at night, which is very typical of a marrow edema and a bone pain, or the child having otherwise okay, only evening time leg pain, which is typical of a growing pain. But when he sleeps, he's okay. So differentiate between the two. So he's got leg pain, he's got some petechiae, so he's becoming sick progressively. He's got that liver spleen, generally lymphadenopathy, and testicular swelling. Now this is the CBC. Hemoglobin is 7, normal MCV, normal MCHC, so normocytic, normochromic. Now here, WBC is today 800, but polymorphs are just 15. So your ANC is less than 400, which is very low. And your platelets are 45,000, which is very low. So this is true pancytopenia as we call. All right. All the three cell are gone. So next is smear. Smear will show you blast, either lymphoblast or a myeloblast, which will show you granules and so on and so forth. The diagnosis is leukemia. So don't mess around with such children. Refer them in time after stabilization. So when you do the marrow in a patient with pancytopenia, as I showed you before, you see megaloblastic anemia. When you see leukemia, you see megaloblastic anemia. You see empty marrow with fat spaces. Done a biopsy which shows empty marrow. That's like hypoplastic or aplastic anemia. You can see storage still like Gaucher cell or Niemann-Pick cell. All right, and very rarely you'll see Kala Azar. Of course, we don't see it very often, but we had a focus of Kala Azar in Kurla area where I'm practicing, and in Eckworth leprosy home. We had an Eckworth leprosy home, which is now, of course, having lesser and lesser patients. Those patients used to be mainly from Bihar and UP. They used to be staying here till the time they're cured of leprosy. They would go back home and come back, and they would bring those sandflies back. And it was a perpetual center for Kala Azar in Bombay. All right. When you have pancytopenia, don't miss these clinical signs. Extra thumb, bifid thumb, microcephalic-like picture, perioral hyperpigmentation as in the second child. You can see an extra thumb. You can see dyskeratosis of the nails, or you can see an absent radius syndrome. These are all typical of what you call constitutional hypoplastic anemia. The top three are the Fanconi's anemia. The right bottom is the dysplastic nail is the congenital dysplastic syndrome, and on your right, the small cute child is a TAR or the thrombocytopenia with absent radius syndrome. Okay, what is this cell? This is a large cell on smear which is nuclear, but what is important is a lot of cytoplasm, and the cytoplasm is indented by the RBCs around it. It's taking the shape of the RBCs, and the nucleus is very open. So this is what you call an atypical lymphocyte. And where do you see this? In many chronic viral infection like EBV, CMV, hepatitis A, and because of drugs like phenytoin. So this is something which you should not mistake as blast. Now, what mistake can lead to temporary remission in a known case of ALL? Hazardous steroid use, or even a single transfusion. We see at least one case every year where someone is treated rheumatoid arthritis, given them steroid, and they come back with relapse. Or someone had anemia, someone gave transfusion, and they came back after 3 months with full-blown blast in the smear. Which of the following is not prone to develop malignancy? Fanconi's anemia, of course, can lead to myeloid leukemia and lymphoid leukemia. Down syndrome, very typical associated with myeloid disease, myeloid leukemia. Previous etoposide, again, is a common cause of treatment-associated myeloid leukemia. Osteopetrosis doesn't come with the malignancy. All right. Again, a small child, you can see with hepatosplenomegaly. So 7-month-old male child, failure to thrive since 3 months, pallor for 2 months, petechiae since 5 days. He had hypocalcemic convulsion at 2 months, which was proven as hypocalcemia, treated with IV calcium, followed by vitamin and calcium, and he became okay. He had pallor, he had petechiae, he had gross hepatosplenomegaly. And he had nystagmus. Now, the reason why he came to me is for this CBC, which was reported by pathologists as hemoglobin of 5, normocytic, WBC 2800 with only 25% poly, so ANC of almost like 600, and a platelet of 45,000, and a blast seen in the peripheral smear. So this is leukemia. What is not fitting into leukemia is he has got retic count of 5%. Now that is very, very unusual to have 1.5 to 2% corrected retic in a child who has got malignancy. So remember, if a child has nystagmus, has a reticulocytosis, this is probably not malignancy. So what I will do is first let us find out, are there any causes of blast on the smear besides leukemia? So yes, you can get in JMML, that is juvenile myelomonocytic leukemia. You can get in myelodysplastic syndrome, osteopetrosis. In a recovering marrow, like in a leukemia, when you give chemo and when they recover, or you are giving them GCSF, they sometimes show blast in the smear for some time. And in infant, blast may be mistaken as actually what are known as hematogon. They are normal cells, but they look like blast. Okay, this shall we did the X-ray chest and X-ray skull, and you can see this is typical of a osteopetrosis. So osteopetrosis will have nystagmus because of the constriction of the optic nerve, hepatosplenomegaly, pushing off all the cells. So they will have shift to left like myelocyte, metamyelocyte, band cell besides blast, and they will have high retic count. All right, one or two cases on the platelet disorder. So this is a well-looking child, but cross petechiae purpura and a subconjunctival hemorrhage. So sudden 10-year-old child, sudden skin bleed for 2 days, mild epistaxis for 1 day, just few drops, no joint bleed, no fever, no body ache, no weight loss, active and went to school till yesterday. So what we call not sick looking child. It's got superficial petechiae and small ecchymosis with that subcutaneous hemorrhage, but no organomegaly like no lymph node, no liver, no spleen. This is a CBC. Hemoglobin index is normal. So RBC series is out. WBC with differential are normal. So that is also normal. Platelets are 18,000. So a single cell line defect of a very low platelet count. And a smear shows that there are few platelets, but they are large platelet and there are no blasts. So this is a typical CBC you will see in a patient of isolated thrombocytopenia. Common disorder will be ITP. So it's not leukemia, it's not dengue, it's not malaria. Just one well child with isolated thrombocytopenia and a large platelet is typical of a ITP. Now, what will come to our rescue if you have to ask for immature platelet fraction? This child, you ask for IPF, it will be high, 10%, 20%, and that tells you it's a regenerative marrow, unlike leukemia where it is a-regenerative, so you don't have to worry about anything else. All right, so well child, no organomegaly, no weight loss, only low platelet. If he has anemia, it's proportionate to the outside bleeding, but he had no anemia, no blast as seen by an expert eye. And if you ask for an IPF, then it will be high and that will be diagnosed as ITP. I normally do marrow before giving steroid, and platelet transfusion is absolutely no in ITP. This child, you give him 10 platelets and you repeat your platelet after 1 hour, it will be just the same as it was before the transfusion. All right. Which of the following is not an ITP mimic? What looks like ITP? So ITP is typical. ALF syndrome, Glanzmann syndrome, Viscodal and Bernard-Soulier. So remember, out of this, Glanzmann syndrome is not ITP because they have normal platelet count, which are not functional. Where ALF comes with thrombocytopenia, Viscodal comes with thrombocytopenia, Bernard-Soulier comes with thrombocytopenia. All right, and this is everyone sees, but of course it comes seasonal. You can see this child, they come with this type of isle in the sea of red. Okay, so 7 days high fever, hematemesis 1 day, petechiae 1 day, sick looking child, icterus is there, pallor is there, mild hepatosplenomegaly, and mucosal bleed. And this is the CBC. Hemoglobin is high, 15.5. WBC is low, and platelets are very low. You also do PT, APTT. PT is normal, APTT little deranged. D dimers are okay. So this is a typical child which we see with fever during the seasonal in the monsoon. So what helps you is high hemoglobin, low platelet and low WBC, dengue fever, especially with the clinical picture of that blanching. Low hemoglobin, low platelet is more like malaria. And you have true pancytopenia, it could be also malignancy. So sick looking child, sudden deterioration, common causes are sepsis, falciparum malaria, dengue, severe enteric, meningococcemia you should not forget, sometimes you may see, and so on and so forth. But with the type of skin rash he had, that was typical of a dengue child. So take home message from the cases that we saw today. Look at each cell line in totality. So RBC, hemoglobin, RBC, indices, RDW. WBC, neutrophil, ANC, lymphocyte, ALC. Platelet, mean platelet volume, IPF. Now you put all these three cell lines together and it will make some sense. Don't forget to do a retic count in a child with anemia because that is a window to the marrow, and also IPF if you have low platelet, again telling you what is happening in the marrow. A good peripheral smear by expert actually can clinch a diagnosis, as I showed you in some of the cases. Anyway, meantime, when you're investigating, do not give platelet indiscriminately. Do not give blood transfusion unless the patient is in failure. Do not give steroid for sure without a bone marrow because you can mask a leukemia which will come back after 3 months with a relapse case, and there will be more confusion rather than helping them by giving erratic blood transfusion and steroid. And never feel shy in taking an opinion from expert because if you refer them in time, the family feels happy that you made the diagnosis with an expert. If you don't send and they go directly, they will never come back to you. So remember, when in doubt, always take an opinion, especially when you have some abnormal counts. Well, I again thank the IIP Kerala and all the people who are involved in today's seminar for giving me this wonderful opportunity to interact with all of you. And I will stop here, and if any questions, I'll be happy to answer.
Thank you, sir. Am I audible, sir?
Yes, sir.
That was an excellent, lucid, and crisp presentation as usual, sir. It could not be better than this from one of the most sought after speakers in IAP.
So nice. Thank
Actually, Nitin Shah sir sets himself high standards and also meets them with pure elegance. Any questions, Shweta, from the chat box?
No, sir. So far, there are no doubts. May I request all participants to please post their doubts in the chat box? We'll be discussing them.
Or they can unmute and ask it. That's okay. Perfectly fine.
So
Good evening,
excellent, sir.
Yes, Dr. Anandkumar.
Yeah, sir. Good evening, sir. So the major issue with our day-to-day practice, what I have seen is the number of TC, isn't the total count. If it goes beyond 11,000 or 12,000 or even 15,000, these people will tell that this count is very high and they will get many GPs, not pediatricians, I telling. Many GPs they are doing like that, and they will fight that. Immediately, parents will take the child to us and they will tell us, sir, count in Malayalam, count what to do. That is increase count what to do. The blood infection, what to do. That is their interpretation. So we should spread the idea that say this total count is age dependent. It varies with age. That is the most important thing because this is the most total count is the most misinterpreted thing by the GPs, not by pediatricians, GPs.
Correct. So I think you should ask the labs where you're sending samples that they should have age-related normals on the right side and don't give adult range, because then that will help. And if they don't obey that, then you change the lab. Once you stop sending them, they will automatically change themselves. But of course, it also helps you because the child is brought to you and you give the correct treatment rather than giving them antibiotic with some GP.
Then importance of eosinophil count, sir. That is what we have to analyze because acute eosinopenia will be there.
So high eosinophil count, which is really significant. You can have borderline eosinophilia like up to 800, 900, very typically allergic disorder, eczema and asthma. But if you have 1,000, 2,000, 5,000, 10,000, that's hypereosinophilic syndrome. And then you will do IgE level. If they are sky high, that is Job syndrome. If they're not sky high, then you need to find out what is the cause of that hypereosinophilic syndrome. So you do organ functions like heart, livers, and lung. If they're okay, put them on follow-up. If they become symptomatic, then short course of steroid helps them. And in past, we used to do them for myeloproliferative syndrome. All these what do you call the mutations for the myeloproliferative syndrome, but they hardly come positive in children. So we have stopped doing because they're expensive, and we generally treat them symptomatically. And one thing you should keep in mind when you have eosinophilia in a patient who is sick, that Hodgkin lymphoma can come with hypereosinophilia.
Then about these things, sir. Then what to do with total count I mentioned. Then platelet. Of course, platelet you have to be very careful. But then HLH, sir. Then another important because if child is deteriorating and once count started decreasing, then definitely you have to suspect HLH and you have to go accordingly. You have to evaluate.
So such children usually will come with hepatosplenomegaly and pancytopenia.
Yes, sir.
Three things will help. One is many of them will have consanguinity if it is congenital HLH. Number two, some of them can have what you call a pigment disorder. So look at the iris to see for partial albinism. And third thing is you will anyway do marrow for pancytopenia and you don't see anything like blast. And you go at the edges of the bone marrow and you see some phagocytes. You do screening tests. You do uric acid, LDH, as I said before. You do fasting triglyceride and ferritin. If ferritin is more than 5,000, fasting triglycerides are very high. 12 hours fasting. That tells you it's probably HLH. And even if there are no hemophagocytes in the marrow, if you all satisfy the criteria of HLH, then treat because there is no time. If you don't treat in time, you will lose the child. Today we start only with steroid and don't give etoposide upfront unless the child is very sick. Or the steroids fail.
Which steroid you prefer, sir?
So we normally give them pulse methylprednisolone, dexamethasone if there is CNS irritation in a small child, because then there may be CNS HLH. But otherwise, you can do methylpred and then make them oral prednisolone. And then you should always work out for primary HLH even in an older child, because some of the primary HLH mutation, especially the syntaxin binding protein mutation, can come even as late as 10 and 15 years. So there is no age at which primary HLH may not come. So always do perforin and granzyme release assay as a functional assay and a whole genome sequencing to see for the mutation for the primary HLH.
Thank you, sir.
Yes.
Sir, one doubt.
Yes,
Sir,
please.
usually in viral fever, the child may vomit on the first or second day.
Correct.
And count will be
I think we lost you,
raised,
madam.
maybe just below 8,000 like that. And most of us tend to start antibiotics. Most of us tend to start antibiotics, seeing the high count.
Correct.
See, I have experience seeing most of the cases after vomiting have total count elevated with polymorphs, high polymorphs.
Correct.
So,
So what I would do is, any child who has got high fever but not sick looking, in between fever the child is okay, and I examine him and I don't find a focus, I don't do any test for the first 3 days. On third or fourth day the fever continues, I would do basic CBC, CRP and a smear, and of course malarial parasite. If I still find don't anything and the child is still intrafebrile period okay, we'll wait for 5 to 6 days, irrespective of what the counts are. Of course, I'll see him after 48 hours. But he may develop a focus like a tonsillitis or something, or otitis. But if I don't find anything, 9 out of 10 times, you will be okay, not give antibiotic, and by 6th day, the fever will start coming down. I mean, that's the way. So counts you do. Like suppose the child counts comes as 2000, you are worried something else is there. The counts are a little high, is not an indication of antibiotic. This is the algorithm you should follow.
yes, sir. Usually the casualty medical officer sets the count that way.
Yeah, shortcuts are always easy, but in long run, actually the patient doesn't like it. If you don't give antibiotic to a patient on 3 out of 4 episodes of fever, he knows that you are a good doctor and they'll keep on coming back to you.
Okay, sir. Thank you.
Okay, someone has asked IPF, MPV interpret in general practice, especially in dengue and ITP. I already said that in a ITP, IPF will be high, but sometimes the platelet count is very low, like 5,000. Machine may not be able to detect IPF. Again, same MPV, if it's high, it is regenerative marrow like ITP. But again, if the platelet is very low, MPV may show a dash. So then you see the smear and you see for large platelet. And that helps you to diagnose this ITP. In a dengue, the platelets are low. Fever is okay, child is bitter, hematocrit is fallen, but the platelets are not rising. They're gone as low as 20,000. Parents are worried what will happen. You do IPF. If IPF is high, you can tell them in next 48 hours the platelet will start jumping. But the IPF is still low, then you know it will take some time. And suppose the fever is gone, the hemoglobin is normal, WBC is normal, platelets are remaining at 10, 12,000. You know now it is ITP induced by dengue. And then again you do IPF is high and you may treat them as a dengue with ITP with or without steroid. So that's the way you will interpret. Now, when you get high platelet count of 5 lakh to 6 lakh, what do you see? So normally very high platelet counts are seen in 2 or 3 conditions. One is Kawasaki, second is iron deficiency anemia, and third is rheumatological condition like JRA. They come with high platelet count. So these are the 3 conditions you will keep in mind.
Sir, I have one doubt.
Yes,
What are the
please.
changes? What are the changes we expect following immunization in CBC? Because
Nothing.
many a times, because many a times when the fever lasts beyond 2 or 3 days, we do CBC, CRP,
Correct.
and so if it is high, can it be due to the immunological?
No, immunization
No.
doesn't lead to high CRP or it doesn't lead to high count. So if you have
Okay, sir.
fever going on beyond 3 days and you have high CRP, high count, that means there is some associated infection which happened and immunization gets the blame.
Okay. Okay, sir. Thank you.
Hello, Dr. C. I am Dr. Teresa Thomas,
Yes.
consultant pediatrician. See, what is the significance of PLCR?
What is that?
Platelet LCR. Then see when
So
they are
see,
doing the
nowadays on the new counter, you get lot of tests like reticular hemoglobin, CHR, PHR. I think you should not go into that because they are still not standardized. They all tell you what is the hemoglobin content, how old is that platelet, is it a new platelet or an old platelet, in what is the hemoglobin in the reticular site, that tells you how much is the iron availability in the last few days and all. I think they are more for research purpose you should really not take them as to consideration in your day-to-day practice.
Okay, thank you, sir.
Sir, there was a question in the chat box. Dr. Jayaprakash asked whether what was the reason for ictus in the second case, which had shown with the megaloblastic anemia.
Yeah, so in megaloblastic anemia, the cause of anemia is intramedullary. There is ineffective erythropoiesis, which means because of absent B12 folate, the precursor of the RBC, which are the nucleated red cells, they are all becoming large because the cytoplasm is accumulated, but the nucleus cannot divide in absence of B12 and folate. And that's the reason why those cells then die. And when they die in the liver, in the bone marrow, they release the bilirubin, which is not converted. And that's why there is ineffective erythropoiesis and hyperbilirubinemia. So megaloblastic anemia, the anemia is intramedullary, and the cause of indirect bilirubinemia is because of the ineffective erythropoiesis. There is no peripheral hemolysis. This is hemolysis within the marrow. And actually, it's not hemolysis, it's the lysis of the RBC precursors.
Okay, sir. Thank you. Any other questions from the audience?
If there are no more questions, we can go for the vote of thanks.
Thank you.
Shweta.
Thank you, Dr. Nitin Shah, sir, for such a wonderful and practical presentation. It was beautiful, and it was we are really honored to be listening to you. Thank you so much, sir. And thanks to all the participants, thanks to Nandakumar sir, all the IEP officials, and all the participants who have gathered here, and for all the active discussions. I'm sure that everybody who have gathered here and all those who are listening through the YouTube have benefited a lot through this session. With the permission, thank you, sir.
Thank you.
Of our chairperson, Dr. Johnny, sir, may we call it a day?
Yeah.
Thank you. Good night, everyone.
Good night, sir.
Thank you, sir.
Thank you so much. I learned a lot.
Bye-bye, sir.
Thank you. Good night, sir. Thank you so much.
Good night.
Let us meet next month on this platform with another new session. Thank you all.
Thank you.